Hi, my name is Kyan Safavi. I'm an anesthesiologist and intensivist at MGH and the Torchiana Fellow at the MGPO. It's my pleasure to be joined by Dr. Shenoy, who's the Associate Chief of Infection Control. And we're talking to you today about the importance of knowing the indications for putting a patient on isolation precautions. So thanks a lot for joining us today, Erica.
Happy to be here.
So first question I have is, what are the most common indications for putting a patient on isolation precautions?
Well, so clinicians will be familiar with the three main ones that we use. So it's contact precautions or contact isolation. That's going to be for bugs like MRSA, VRE, your multi-drug resistant gram-negatives, and CREs as a category of that. You've got your airborne transmitted diseases, so those are TB, varicella, and measles. So those are the ones like the big ones, but there's lots more. And then the droplet precautions ones, these are the ones we're going to talk about a lot today. Droplet are your influenza, your pertussis, and Neisseria meningitidis. And basically we use those for to prevent transmission between patients and providers.
And why is it so important to make sure that we're only putting patients on precautions, on isolation precautions who need to be?
Right, so first of all, we only want to do this for patients who actually require isolation. And part of that's because there's some consequences to putting someone on isolation. So when someone's on isolation and we can't find a match, and we have a lot of semi-private rooms in our hospital, that second bed can be blocked. And you know our capacity situation, and so that can lead to kind of inefficiencies, and we'd love to be able to use those beds. So each day there may be 25, 30 or so beds that are blocked for infection control reasons in this hospital. Now, many of them, I would say the majority, are needed, but in cases where we can open up a bed, we can also try to decompress the hospital that way.
That's great. So we're heading obviously into respiratory virus season, so it seems especially important that we talk about the isolation guidelines for those respiratory viruses. So can you tell us which respiratory viruses we should be isolating for and at what point for the patient?
Sure. So let's start with the most common, flu season. Flu season is here. It is starting. So for flu, we empirically isolate patients before we even know the result of the test. So when you think that someone could have flu, you're going to isolate them, put them on droplet isolation, and you're going to send the test. That test is a combined influenza RSV PCR test. It's a very rapid test, very high sensitivity and specificity. It's a great test. From start to finish, we estimate the turnaround time is about 2 hours. So during that time, you want to make sure that your patient is on droplet isolation. When the test comes back negative for flu, you can stop droplet isolation. If it's RSV that comes back, look it up, because it depends on what patient population you're dealing with, whether or not we isolate those patients. And in fact, it's not droplet for adults, it's contact if they're immune compromised. So that's like a little distinction that you don't need to memorize. I certainly don't memorize. I have pieces of paper that I look it up on.
Good to know even you need pieces of paper
Yes,
sometimes.
I do.
So can you tell me about adenovirus, parainfluenza, human metapneumovirus, those other viruses on the panel?
Well, so those are on the respiratory viral panel, and the first thing to think about is it's different from when you order flu, because we do not empirically isolate for these diseases. We wait until they're laboratory confirmed. And so while I know clinicians, they try to do the right thing, they think I'm testing for these viruses, I must have to isolate them. It's actually not true. It's not consistent with our policy or with the guidance that we have from CDC.
Got it. So can you also tell us, what are the indications for getting a respiratory viral panel at all?
Yeah. So like any test, we have to think, what are we going to do differently in terms of management, right? So as an example, with the viral respiratory panel, which is testing for adeno, for human metapneumovirus, and for parainfluenza on the outpatient setting, this is really only used or really indicated for immunocompromised hosts and children. On the inpatient setting, those are also the kinds of hosts that you would be looking for this, but we also allow it to be tested more broadly because we do isolate for certain conditions, certain diseases, if they are positive. An example would be adenovirus in an adult who has pneumonia. So the point being that if you have a patient who has a respiratory illness, they're negative for flu and RSV, is adeno being positive in a normal adult, non-immunocompromised host going to change anything that you do? We do not have really a treatment that we're going to offer, and we would actually not isolate that patient. So as much as possible, it's really important, like with all the tests that we do, to think, how is that going to change management, in this case clinically and infection control wise.
Great. And maybe can you sum up some of the more common examples that you see of patients being on isolation precautions when they don't need to be?
I think for the most part, especially this time of year, it's that confusion around the respiratory viral panel, which happens every year. And like I said, I think clinicians are really trying to do the right thing. They think they must have to isolate those patients, but really we don't. And so those are the ones I think for the most part we want people to focus a little bit more on this year.
And if we have questions about flu testing or putting a patient on isolation precautions, how do we get in contact with you?
So infection control is always available to help you. We're at 62036. I think we're going to have links at the bottom of this page. I'll point this way if that's where the link is. And then we put it at the top of the infection control website. So Partners P, clinical references, and it's listed under MGH Infection Control Unit. There we have these very handy sheets that tell you for adult and PD patients, so this is what I look up, it's on my hot links, what to do in terms of which isolation, droplet contact combo, how long, and who to call for help. So I think those are very good resources that everyone can use.
Awesome. So a real quick summary, when you test for influenza A and influenza B, the patient should be maintained on isolation precautions. Droplet precautions, and when those tests come back negative, we can lift those precautions, and especially as we wait for other respiratory viral panel viruses to come back, we don't need to maintain droplet precautions.
Yes, two things I would say, like we talked about, you maybe don't even need that respiratory viral panel, so think about that. The other piece, this comes up every year, and it's already started to come up this year, is sometimes there can be disagreements between the teams in the ED and the medicine teams admitting or other teams admitting, and we recognize that there are differences in how people are viewing the patient. The differences that arise really result around whether or not the patient needs to be tested for influenza or not, or in the setting of a negative test, is someone really still believes they might have influenza. These conversations have led us to develop an algorithm between the ED and Department of Medicine that's reviewed every year. It's also linked to on our website and basically allows for an escalation in terms of trying to resolve that conflict. In the end, it ends up at the very top, DEFCON level 1 or whatever you want to call it, with me or Paul Bittinger, and we kind of talk to the teams and try to figure out the best way because of that issue related to do they need to be isolated or not. So you have resources available to you. We're here if you need anything.
That was awesome. Thank you so much, Dr. Shenoy. I
You're
appreciate
welcome.
it.
Yep. Thanks.